Symptoms are two great kind of within two great kind of categories. So there is the first one that is the um, inattention kind of first big area, and inattention within in the inattention area, obviously that could be always often fails to give close attention to details, or makes careless mistake in school work, or overlook or misses details, difficulty in sustaining attention in task, especially if the tasks are repetitive tasks or are tasks that the child do not like. They are quite, they can misplace things, or forgetting things that are, or losing things that are utilized for school work. So I don't know, forgetting to bring the book at school, or forgetting other kind of tools that are needed at school to the different kind of activities. The other area, within that, there is also a really, really huge difficulties to organizing things for the children, and create kind of a priority, prioritizing a priority agenda for the different kind of tasks. Often they are as I was saying, avoiding the dislikes, room activities, and for this reason are obviously usually quite messy. Their kind of environment, their room, or their desk where they have the activity for the school activity, and they are really, really easily distracted by even really minimal noise, or other kind of things. These are roughly in the inattention area. Then the other big area is the area of the hyperactivity and impulsivity, that differently with the adult, because the hyperactivity is usually more prevalent within the child, within the children age, while growing up and arriving to the adult age, usually the patient, it is a big difference between the two kind of age. The hyperactivity tend a little bit to reduce and not disappear, but also, the patient usually manage to find coping mechanism to kind of hide this kind of aspect, or to other different things. But in the hyperactivity, within the hyperactivity area, we got fidgeting, scream, often leave, not able to stay sit during the lesson. They are quite loud and interrupting others' conversation before they are finishing to say what they are currently saying. Runs, climbing, engaging also in a quite dangerous behavior, are usually unable to play or engage in leisure activity with the quietly, as I was saying, are quite loud and disruptive usually. They can also, I like constantly going, like if they are kind of driven by a motor, often on the go. And this is also, it's not just physically, but also mentally. They always have this kind of feeling to have this train of thought that are always really, really, really quickly. As I was saying, talking excessively, answering or brought with answer before the question has been completed. Difficulty in waiting if they are queuing or waiting their turn, if they have to wait for any reason, interrupting others. I mean, these are the main kind of symptoms for the two area. In terms of impulsivity, I mean, first of all these symptoms needs to be present before the age of 12 to have a diagnosis. In terms of impulsivity, as I was saying, they can also, as I was saying before, engage in dangerous behavior for the incapacity to control their kind of impulse and making really impulsive decision without thinking of the consequences. And for this reason, as I was saying, there could be also this kind of issue in engaging in dangerous behavior that can lead also to serious incident. As I was saying, for the adult, is roughly the same. Also in the adults, I mean, symptoms needs to be present before the age of 12, and for this reason also when the, I think we will speak about that later, but within the diagnostic process for the adult, there is also a questionnaire for the childhood that needs to be filled in by parents or relatives that know the patient when he was a child, to describe how he was and the symptoms when he was a child. And the symptoms are the same, can be slightly different, and sometimes obviously there are less sometimes evident, because patients also, they are able to kind of put in place some coping mechanism to kind of trying to making things works for them. But as adults, you always find situation where or they didn't achieve their potential, or sometimes they are also quite good in their professional life because they choose to do, usually they are patients that kind of perform well are usually self-employed or are usually working in area that is more kind of a creative area. But the symptoms are the same. As I was saying, they are less prevalent, the hyperactive component that growing up is a lot reduced, even if they were a lot more hyperactive. But there are the combined, obviously, there are in probably I would say in less kind of percentage the combined type also in the adult, but it's less in terms of percentage compared to the children. Symptoms are the same for the inattentive area and for the hyperactive area and impulsivity. In the adult, what you can find also other probably other comorbidity if the patient has engaged in dangerous behavior. So you can find quite frequently also substance misuse, or you can find in male and female. In female, you can find depression and anxiety that are quite frequent and mostly diagnosed together as a co-diagnosis. You can find also post-traumatic stress disorder as a co-diagnosis. Sometimes always, I mean, for the same kind of reason, because this kind of tendency to engage in dangerous behavior can obviously lead to traumatic experience, and then obviously also this linked for the post-traumatic stress disorder. ADHD diagnosis is a quite a thorough process where the patient go through. I mean, I'm not personally involved in children assessment and diagnosis. I'm just involved with adults. But with adults, it's quite a thorough process that also include a full mental health assessment, and then also the patient is provided with the DIVA, that is a questionnaire that the patient will have to fill in, where there are obviously the two different areas of inattention area and hyperactive area, where the patient has to cross different kind of example symptoms in relation to different questions. And as I was saying before, there's also the child would questionnaire that is filled in by the parents or relatives that knows the patient when he was a child. That is the interview for adult ADHD parent or adult questionnaire is called. The DIVA 5, that is the diagnostic interview for ADHD in adults, is the one that is filled in by the patient. With these two questionnaire after the full ADHD assessment, so patient usually, first arrive when arrived to the clinic is triaged, and during the triage, patient are assessed and recorded for the full medical review. Then they are booked for the full mental health assessment and discussion of the results of the questionnaire of the DIVA and the questionnaire for the parents. At the end of all this process that takes, as I was saying, the part of the triage, the part of the patient doing the questionnaire, and then the full mental health assessment by the psychiatrist. There is the review of the questionnaire, that at the end of all this process, according, obviously, in line with the DSM-5 or the ICD-10, whatever, wants to be considered as a kind of an international recognized statistic manual for the mental disorder. The patient, the psychiatrist give to the patient the answer if patient met or not the criteria for the ADHD. During, obviously, the full mental health assessment, a lot of other possible diagnoses need to be excluded and within the full mental health assessment, and this is roughly the process and tools used for the assessment. Treatment options for managing ADHD are pharmacological and also not pharmacological. Not pharmacological, there are different kind of option in terms of talking therapy. There are other supportive application apps that have been created. Also really good also is to peer-to-peer support that is offered sometimes. This is offered by different kind of patient group within the UK. For the pharmacological part, by the NICE guidance, the first line of treatment is amphetamine, medication within the amphetamine family, and usually first line of treatment are methylphenidate or lisdexamfetamine, and they are the extended release. I'm talking about the adult. In children, as I say, I'm not an expert for the children, but in children you can sometimes see a little bit more even the instant release compared to the adults. Medication that have to be taken 2 or 3 times a day, usually, instead differently from the slow release from medication, the XL, the methylphenidate or the dexamphetamine. The other line, so there are the first line of treatment are the amphetamine-based medication. The second line are the non-amphetamine-based medication, like the atomoxetine. Then there are other medication like the guanfacine or the bupropion, and other molecules that are used less frequently. This is, in general, the treatment, possible treatment for the ADHD. Unfortunately, ADHD is a neurodevelopment disorder and is considered a long life disease. This is also one of the big issue with health insurance company that after the diagnosis they are not recognizing, unfortunately, for this reason, the pharmacological treatment after the diagnosis, because it's a neurodevelopmental disorder. But differently from what thought, there are a component, roughly a third of the patient, that after 2 years of pharmacological treatment, especially if they also had other talking therapy or other approach together with the pharmacological therapy, after 2 years, roughly, if they try to stop the medication, they can roughly maintain the same kind of improvement in their symptomatology. There are another third, roughly, of patients that when they stop, they maintain the same kind of level of improvement, but then if they are going through a particularly stressing period for any reason, they will have to go back to the pharmacological treatment. And then there is a kind of last roughly third of patient that unfortunately, as soon as they stop the medication, everything goes back at square one, and everything and the symptoms come back exactly as were before they started with medication. So they need to carry on, obviously, if this is necessary. Okay, so apart, obviously, as we discussed previously, the pharmacological therapy and also the talking therapy that can help. I would say majority of the times, quite significantly, the daily life of this patient. Only a little bit, I would definitely say a minority of patients, we are not able to find the right kind of balance in the pharmacological therapy and together with the talking therapy. In general kind of things, we always, advise the patient to commence ADHD coaching to find ways of managing the symptoms, also the importance of generally of life modification that could include, obviously, maintaining, and this is a general kind of advice that could be obviously good for every kind of mental health disease: maintaining a healthy social life, exercising, eating healthily, engaging in hobbies that he enjoys, and there are natural, obviously, all these are natural sources of dopamine. Other things that we usually advise the patient to do is to there are different apps now on telephone, on your phone, that you can download from the web. We usually advise one that is called Elevate, that is specifically designed for people with ADHD to improve the sustained attention. And usually this kind of apps needs to be used, around 15-20 minutes every day. And this help the patient to, as I was saying, improve the sustained attention. The other kind of things that I've also mentioned before are also this peer support. And there are this big on the web, a big patient group where the patient can really be supported by other patients with ADHD that they went through, obviously, the same kind of experience, the same kind of difficulties and challenges. And within the group is really, really helpful. This is one of the things that I'm always advising my patient to get involved with, because are quite helpful for them in finding advice in different challenging situations on how to manage their kind of daily activity, how they can improve their kind of incapacity to organize their time, what could be, things that they can put in place, or different kind of idea and solution to different kind of challenge or daily challenge for the patient. This is roughly generally what we advise to the patient out of the pharmacological and psychotherapy part.